Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Stent Thrombosis in Distal LM Stents. This is a case from Colombia, not in the Excel trial. This is 84 years old female, and patient had bypass about 20 years ago, and currently only patent SVG2 right coronary artery. And patient having the stable angina due to this unprotected distal left main 111 lesion. And especially you can see the circumflex ostium is quite tight. This is the index procedure sequence, predilatation in the LAD and circumflex ostium, and then circumflex to left main stent 3524, and POT was performed using the 4. After rewire, the mid LAD was stented 3538, and then the LAD left main stent 3524. So this is how it looks like the wiring into the circumflex. And then LAD left main ballooning, and then circumflex left main ballooning, and the KVT using 3535. This is how it looks like the final picture. 6 weeks later, the patient come back to the ER due to the acute burning, chest discomfort, and diagnosed as non-STEMI. At the time, the medication was ticagrelor and aspirin. Angiography showed the hedginess of the circumflex ostium, and in this view, you may think this looks like thrombus. This is IVUS picture at the time of the index procedure at the end of the procedure from circumflex to the left main. I can see the medial dissection at the edge of the stent, and even more clear, and this is a stent edge. And this side is even the eccentric calcium stent expansion seems to be okay by stretching the normal side. This is limas, here carina, and bifurcation, and now in the left main. And you can see the double layer. At the end of the stent, there is some malposition. Let's talk the most important in terms of the circumflex ostium. Here is the circumflex ostium, limas, ostium, and left main. So what's happening is there is a limas. This limas is not big territory, but in terms of the diameter, is not so small. At the site of the carina, between the circ and limas, of course there is a stent slot, but after merging to the limas, the carina of the circ, there is no stent slot, and there is a medial dissection, and this is a guide wire, so there is a stent slot here and here, so seems to be double layer of the stent slot at the non-carina side of the circumflex ostium. In terms of the stent expansion, LAD and left main seems to be okay. Circumflex ostium measured 5.2 square millimeter, which is moderately under expanded. This is how it looks like the IVUS picture 6 weeks later, and it seems to be the distal edge dissection was healed. And here is the stent edge, and because of 6 weeks, there is no neointium at all, and coming back to the ostium. You can see the organized thrombus, which protruding to the left main. This is a summary at the index procedure final at 6 weeks later. And as we discussed, there is a no stent slat here and medial dissection, double lay of the stent in non-collinear side, and moderately underexpanded. And 6 weeks later, we can see the organized thrombus here protruding to the left main. So what could be the cause? Circumflex left main was stented and pot, and after rewire and balloon, at the site of the circumflex ostium is actually because of the limas. This stent slat never attach fully to the vessel wall, actually cross over to the limas. Already left main stent and then rewire to the circ from the distal cell. And because of the osteocircumflex was never attached to the vessel wall, and this wire is bringing to the strut at the circumflex ostium, move to non-collinear site, and then finally this portion was not covered and remain medial dissection. And this is what we can see. This type of the mechanical issue is not infrequent in the Excel trial. We see this type of the incomplete clash at the circumflex ostium or stent gap at the circumflex ostium. In the Excel trial, there is 127 cases having the two-stent technique and final IVUS. Out of those, 28% of the cases having the incompletely clashed stent, and 11% of the cases having the stent gap at the circumflex ostium, which is frequent in the T-stent or clash, but still sometimes we see in the Kirot stenting. What should have been done? Because there was a limas branch, the stent slat at the collinear side of circumflex ostium or limas ostium was never attached to the vessel wall. After rewiring to the circumflex from distal cell, the stent slat at the circumflex collinear was moved to non-collinear side. Along with the moderate and expanded stent at circumflex ostium, thrombus was observed at the collinear of circumflex 6 weeks later. Thank you very much.